We are still not at quorum, so let's give our board member just a few more minutes to join us. All right, we are at quorum this morning. Good morning, everyone, and welcome to April DUR meeting. And a few reminders for our meeting today. If you are dialing in via telephone, Google Meet has muted you. If you need to speak to the group, please press *6 on your phone to unmute and mute. We kindly ask that only those who are speaking to the group unmute their device via Google Meet. DUR board member, please reserve questions until the end of presentation or ask in the Google Meet chat. For public comment, if you would like to provide a public comment, a COI must be on file. Please send an email to medicaidpharmacy@utah.gov. Attendees that are not members of the DUR board, please enter your contact information in the Google Meet chat or send an email to medicaidpharmacy@utah.gov. Please use the chat on the right if needed. Please provide normative feedback after the meeting to help us improve our process moving forward. Thank you, and I will leave it to Dr. Cannon.
All right. Good morning, everyone. We had some sun this week, so welcome to a rainy day, I guess, in Salt Lake. We were close to having a full week of sun. Anyway, welcome, everyone. Everybody should have received a copy of the minutes. Hopefully, everyone's had a chance to review them. Were there any questions or comments, proposed changes that we need to address in the minutes? Kumar? Okay, you were muted, but I'm guessing you proposed that we accept them. All right, Kumara's motion that we accept the minutes. Do we have a second?
Second.
All right, all in favor?
Aye.
All right. Motion passes and the minutes are approved. I'm going to turn the time over to the University of Utah for us to talk about pediatric pulmonary hypertension. I apologize. I am going to have to step out for a moment at 7:30. Hopefully I'll be right back. But in my absence for a period of time there, Noon will handle things. So I don't know who has it from the University of Utah, but we'll turn it over to them now.
Okay. Just give me 1 second to share those slides. Hopefully you can see all those now. Good morning. Today I will be reviewing the management of pediatric pulmonary arterial hypertension, abbreviated PAH. Throughout this presentation, I will refer to drugs that are FDA approved for PAH as PAH-specific pharmacotherapies. PAH is a rare progressive disease characterized by increased pulmonary arterial pressure and pulmonary vascular resistance. This disease occurs in infants and children as well as adults. Hemodynamically, pulmonary hypertension in pediatric patients greater than 3 months of age is defined as a mean pulmonary arterial pressure above 20 millimeters of mercury, which is the same definition used for adults. To identify precapillary pulmonary hypertension, which is characteristic of PAH and some other pulmonary hypertension types, additional thresholds for pulmonary vascular resistance index and pulmonary arterial red pressure must also be met. PAH is classified as group 1 pulmonary hypertension among 5 total classes of pulmonary hypertensive disorders. PAH can arise either idiopathically or secondary to other contributing conditions. The 6 subclassifications of PAH are outlined on the slide and include persistent pulmonary hypertension of the newborn, abbreviated PPHN, which will be discussed further on the next slide. The predominant etiologies in children are IPH, HPH, and PH-CHD. If left untreated, PAH more rapidly progresses into right ventricular heart failure and eventual death. Before targeted PAH treatments became available, survival from time of diagnosis in children with IPH was typically 1 to 2 years. With increased availability of targeted PAH treatments, the predicted 5-year survival rate is approximately 60% to 75% for pediatric patients with certain PAH subsets. The majority of pediatric PAH cases occur during infancy. These cases tend to be diagnosed as either repairable cardiac shunt defects or PPHN. Typically, PPHN is characterized as a sustained increase in pulmonary vascular resistance with persistent hypoxemia due to maladaptation of the fetal pulmonary circulatory system during transition to postnatal life. Because PPHN is a syndrome with several related disorders, there tends to be a high risk of mortality requiring prompt medical treatment. Agents FDA approved for the treatment of PAH consist of PDE5 inhibitors, ERAs, and prostacyclin analogs. Although all the agents listed on the slide may be used for the treatment of PAH in pediatric patients, not all of them are FDA approved for this age group. Of these, only bocetin is specifically approved for use in pediatric patients. Most other agents are labeled more generally without an approved age for use. The exception is sildenafil, which is approved for adult use only. U.S. product labeling recommends against pediatric use of sildenafil, particularly long-term, due to a dose-dependent increase in the risk of mortality observed in an uncontrolled study. Sildenafil is approved by the European Medicines Agency, abbreviated EMA, for pediatric patients. Ambrisentan, which does not specify an approved age for use in U.S. labeling, is also approved by the EMA for pediatric use. Although each of the reviewed agents are approved for PAH, the indicated purpose for use in PAH varies by agent and in some instances by formulation, as highlighted in blue text on the slide. Inhaled formulations of treprostinil are also FDA approved for pulmonary hypertension secondary to interstitial lung disease. Two guidelines provided pharmacotherapy recommendations for pediatric PAH, a 2022 European guideline and an older 2015 US-based guideline. To supplement guideline recommendations, we included guidance from international experts in pediatric PAH. Multi-parameter assessment is recommended by clinical practice guidelines for determining disease severity. The World Health Organization functional class, abbreviated WHOFC, is one of the many parameters used to describe PAH disease severity. The WHOFC is a strong predictor of survival in pediatric patients and can be used for setting treatment goals. Nevertheless, it may be challenging to assign young children a WHOFC due to the absence of exercise standards in children under 8 years of age and the limited number of RCTs available for therapy guidance. Other parameters include the 6-minute walk distance test in patients 6 years of age and older, and certain laboratory assessments. A comprehensive diagnostic workup tailored to age is recommended by guidelines to ensure a correct diagnosis and treatment strategy. It is important to consider age appropriateness of tests. With the exception of PPHN, the gold standard for diagnosing pulmonary hypertension in children is right heart catheterization. It is recommended to be performed before PH-specific treatment is initiated. However, exceptions may exist, such as critically ill patients who need to start empiric treatment immediately. In children with pulmonary hypertension, cardiac catheterization can cause serious complications, especially for those in a poor clinical state or young infants. Therefore, it is recommended to perform cardiac catheterization after weighing the individualized benefits and risks and within a specialized pulmonary hypertension center, preferably one that is experienced in pediatric management. The guidelines differ on for repeat cardiac catheterization. The 2015 AHA-ATS guideline recommends repeat cardiac catheterizations within 3 to 12 months after starting treatment to determine treatment response or with clinical deterioration. However, the newer ESC-ERS guideline describes that indications for repeated right heart catheterization in children with pulmonary hypertension are currently not well defined. The gold standard for diagnosing PPHN is echocardiography. Right heart catheterization may have limited utility or may even be contraindicated in infants with suspected PPHN. Additionally, PPHN is defined clinically, not based on certain hemodynamic thresholds. Candidacy for calcium channel blockers, or CCBs, for the treatment of PAH is determined by acute vasoreactivity testing during right heart catheterization. The 2015 AHA-ATS guideline recommends vasoreactivity testing unless a contraindication exists, whereas the 2022 ESC-ERS guideline recommends vasoreactivity testing only for select patients based on the PAH subtype. In the absence of contraindications, off-label use of oral CCBs are recommended for children who have a positive vasoactivity response and who are at least 1 year of age. Because the 2022 ESCRS guideline recommends vasoactivity testing only for patients with IPH or HPH, CCB use is only recommended for patients with those subtypes. CCBs should not be used in a variety of clinical scenarios, including as empiric treatment of PAH when vasoactivity testing cannot be performed, patients who are non-vasoreactive, or if the patient has right-sided heart failure. Additionally, off-label use of CCBs may be considered inappropriate based on the provider's clinical judgment in scenarios where evidence is lacking for a particular PAH subtype, or when the risks of performing vasoactivity testing and thus using CCBs are too high. When patients with PAH are not candidates for vasoactivity testing or CCBs, a PAH-specific agent should be initiated. Risk stratification is used to guide treatment decisions for pediatric patients who are inappropriate for CCBs or who have an inadequate or non-sustained response to CCBs. This slide shows the many parameters that are considered in determining a patient's risk of a poor prognosis. Although treatment goals are individualized, the 2022 ESCRS guideline recommends acquiring a low-risk category and sustaining the lower risk profile, which can be an indicator of a positive treatment response. Recommended initial treatment for lower risk patients is oral monotherapy with either an ERA or PDE5 inhibitor. Early treatment with an inhaled prostacyclin, early combination treatment with an inhaled prostacyclin analog may also be beneficial for these patients, especially those who experience clinical worsening. Higher risk patients should be immediately initiated on a subcutaneous or intravenous prostacyclin analog. Early combination treatment can also be considered for these patients. Because a 2019 European consensus, based on a 2019 European consensus statement, early triple combination treatment with an intravenous or subcutaneous prostacyclin agonist, in addition to an oral PDE5 inhibitor and ERA, can be considered. Regarding transitioning from parenteral to inhaled or oral preparations, the 2015 AHA-ATS guideline recommends considering transitioning when patients improve to an asymptomatic status with continual near-normal pulmonary hemodynamic parameters. Lung transplant and interventional palliative surgery should be considered in higher risk patients who experience clinical worsening despite optimal pharmacologic interventions or who are unable to access pH-specific agents. The vasodilator of choice for treating PPHN is inhaled nitric oxide. The 2015 AHA-ATS guideline recommends sildenafil as an adjunct to inhaled nitric oxide in infants who have refractive PPHN, particularly if the oxygenation index is greater than 25. An inhaled prostacyclin analog can also be used as adjunctive treatment for nitric oxide-resistant PPHN in infants with an oxygenation index greater than 25, but the guideline recommendation strength is lower. The 2022 ESCRS guideline provides a summary of the level of evidence available at the time of their review for the use of pH-specific agents in the pediatric population. Although older, the 2015 AHA-ATS guideline denotes a recommendation class for each agent based on the level of evidence available at that time. Treatment algorithms for pediatric patients are extrapolated from adults and supplemented by evidence from observational studies of children with PAH. Newer agents used for adult PAH, including selexipag and riociguat, had insufficient evidence in pediatric patients at the time of the 2022 guidelines evidence review. To supplement guideline evidence, we screened systematic reviews to determine if additional pediatric RCTs were available for PAH agents. We found additional RCT evidence for iloprost, intravenous treprostinil, bosutin, and macitentan. And for sildenafil, we identified a 2020 systematic review meta-analysis, or SRMA, of RCTs. The RCTs and SRMA were generally supportive of the mentioned agents, with the exception of the RCT for macitentan, which did not find a significant difference compared to placebo. This slide reviews off-label indications indexed in LexiComp and in Micromedics as effective or evidence favors efficacy. The only pediatric off-label use index for these agents is for sildenafil for the treatment of PPHN. Micromedics and Lexicomp also have a number of adult off-label uses indexed for epoprostenol, iloprost, bocetin, sildenafil, and tadalafil. Over the next 3 slides, I'll highlight the possible clarifications or modifications to the current prior authorization criteria in place for the treatment of PAH. Although the adult proposed modifications have also been included on the slides for convenience, I will only discuss the rationale for the proposed changes related to pediatric patients because those for adults were presented last month. The PA criteria, last updated June 2022, requires the diagnosis of PAH to be confirmed by right heart catheterization in adults and documentation of mean pulmonary arterial pressure. For pediatric patients, consider having separate diagnostic criteria for PAH and PPHN. For PAH, diagnosis should be confirmed by right heart catheterization and supported with a historical MPAP of greater than 20 millimeters of mercury in treatment-naive patients. For PPHN, diagnosis should be supported by echocardiography findings. Medical necessity may be considered in cases where right heart catheterization would be inappropriate. Additionally, it seems that the PA requires all patients to have acute vasoactivity testing and to step through off-label use of CCBs before receiving agents approved for PAH. However, according to the 2022 ESCRS guideline, only certain subsets of PAH patients are recommended to undergo vasoactivity testing and the CCB therapy. And the recommended age for use by the 2015 AHA-ATS guideline is at least 1 year of age. This criterion could be specified for certain PAH subtypes in patients 1 year of age and older, and allow the provider to attest when the use of vasoactivity testing or CCBs is inappropriate for their patient. Alternatively, this criterion requiring off-label use of CCBs may be considered for removal. According to the PA form, it appears that patients are allowed to start a PAH-specific or PAH agent only if they are in a functional class 2 or higher. However, it may be particularly challenging to assign young children a functional class. Additionally, this criterion may not take into account the nuances of treatment-experienced patients who have improved to functional class 1, but who request a switch in treatment due to either poor tolerability or transitioning from intravenous to oral therapy. It is unclear if this criterion is required for members upon reauthorization. Overall, this criterion can be considered for removal. Because PAH-specific agents are not curative, patients with PAH, except possibly PPHN, require chronic, potentially lifelong use. Consider removing the criteria for reauthorization or alternatively extending the reauthorization period to every 9 or 12 months to minimize the potential for treatment interruptions. The requirement to demonstrate a positive clinical response at reauthorization may be considered for removal, or additional markers for improved or maintained disease severity can be included. FEV1 is not included in either of the reviewed guidelines as an indicator of a positive PAH response. Additionally, the 6-minute walk distance test may not be age appropriate for younger children and is only one of the many assessments that are taken into consideration to determine risk stratification. There are other markers of improved disease severity aside from 6-minute walk distance tests and other unique approved indications for PAH agents that span a variety of purposes. Notably, several drugs are approved to slow disease progression, not necessarily to improve exercise capacity or other laboratory markers. So positive response is more nuanced and may be reflective of a slower rate of decline. The current PA form requires the provider to check the PAH therapies that the patient has tried and failed. Similar to adults, guidelines recommend monotherapy or combination therapy regimens of differing drug classes for the treatment of PAH in pediatric patients, depending on disease severity. If a drug regimen had an inadequate result, the individual agents themselves may not necessarily be considered as failed because they can be tried in alternative regimens, which may result in clinical improvement. It is unclear if the documentation of a failed agent on the current PA would prevent coverage of that drug in the future. Also, may consider incorporation as space into the current PA form or in a separate drug-specific PA form to allow the prescriber to submit a PA request for other on-label uses for some of these agents and perhaps off-label uses if supported by treatment guidelines and/or indexed in a recognized pharmacy compendium. Regarding utilization for pharmacy claims in 2022, there were 20 unique pediatric patients who utilized a PH-specific agent of interest, accounting for a total of 144 claims. Based on total claim counts, generic sildenafil had the highest utilization, followed by generic tadalafil, brand ambrisentan, and brand bocetin. In the pediatric population, no pharmacy claims were found for the remaining agents of interest, and no medical claims were found for any PH-specific agent of interest. Thank you for your time and attention. Please let me know if you have any questions.
Thank you, Dr. Lulo. Do the board have any question for Dr. Lulo? We can move on to the pulmonary arterial hypertension prior authorization presented by Luis Moreno.
Hello, everyone. So I have the draft of the newly revised PAH form, PA form. And so I'll go through each of the modifications that we made. First, I'd like to point out.
Luis, we cannot see. Okay, it's on right now. Thanks, Luis.
Oh, yeah, no problem. Okay, so we're good, right? Everybody see it?
Yes.
All right, so first is the title. Before it was pulmonary arterial hypertension, but we have modified it to the umbrella term of pulmonary hypertension, because as we know, PAH is just one of the groups of pulmonary hypertension. So we wanted to be more broad with the title. And then down here, we left this the same as far as which products are being requested under this PA, and we also have the bolded preferred products on the list. In terms of the criteria, we left the requirement that a pulmonologist or cardiologist specialist should be ordering these. And then we modified the diagnosis section, and we made it more broad for pulmonary hypertension, where the provider will indicate what group of pulmonary hypertension the patient has, instead of asking for a mean pulmonary arterial pressure and all of that. It seems like it's too detailed for the diagnosis. We just want to know which group they have. So we made that change there. And we also included groups 3 and 4, which are the indications for the medications in parentheses, which we didn't have before. And as the DRRC recommended for this bullet here, adult patient has a history of WHO functional class 2, 3, and 4. They did recommend to include the wording a history of, so as not to confuse with what the functional class is at the time of the PA request, because the patient might have already been taking these medications and their functional class might have improved. So we wanted to just be more clear in requiring a history, 2, 3, or 4. And also we changed it to the adult patient because sometimes that is not possible to assign a WHO functional class for children. Down here in this section, we changed the wording from failed, indicate all the following medications that the patient has failed, to the word trialed. So the DRRC indicated. It might be a little clearer for the provider to list the medications the patient has trialed rather than failed. In this section for non-preferred product, we added the continuation of therapy to make it clear for the provider that a patient who's already on a regimen may continue on that regimen if the patient meets the COC criteria. And also, with the reauthorization criteria, we agree with the DRRC recommendation that the criteria that we had previously requiring a 6-minute walk test or FEEV1 is not completely relevant or accurate because this is a chronic disease. And so the provider can write a summary on the chart notes, pretty much stating why the patient needs to continue on the requested medication. And it could include anything from lab assessments, 6-minute walk tests, if appropriate, if the patient is the right age, WHO functional class, or even just write, if according to their clinical rationale, the drug has slowed the rate of decline for this patient. So all of those criteria would meet the requirement for reauthorization in the new form. And we also updated the reauthorization criteria from 6 months to 12 months, given the chronic characteristics of this disease state. And that is all I have to share. Any questions?
I have one. This is Valerie from the DRRC. Thank you so much, Dr. Moreno, for presenting those. The only thing I saw was for that functional class criterion. Would it be possible to tie that to group 1, since that criterion is designed for group 1? Because we didn't review fully the treatment for group 3 and 4. So I don't know if WHO functional class is a factor that's considered for those groups to initiate or continue therapy.
Okay, so you're saying to make it clear in that bullet, so saying for adult patients with group 1, parentheses PH, patient has a history of WHO functional class 2, 3, or 4?
Right.
Okay. Thank you for that clarification.
Sure.
This is Dr. Weinstein. So are you suggesting you would just move that line, adult patient with history of functional class, up under the group 1 box?
I think either one. I think even if some clarification is stated where it is now, just to say like, okay, this is specifically for the group 1 patients, whatever makes it most clear for the provider, I guess.
Okay. I mean, just as a form goes, if it only applies to group 1, I think I might just put the line there underneath group 1 in the form. So if you're filling out for group 1, then you would just fill out that line and then it wouldn't apply coming down. Which leads me to a question I had is, and this is complicated for somebody who doesn't do this work, so forgive me if I'm showing my ignorance. We have no line for group 2, right? On the form.
Correct. Yes, because the medications for this particular PA pertain mainly to PAH group 1, and then also 3 and 4, with specific drugs in parentheses for groups 3 and 4. Right. That's what I thought.
And we don't need to have a no, that won't confuse the specialists. only the ignorant. Thank you.
No problem, Dr. Weinstein.
So this would be used for pediatric patients as well?
Correct. It's been modified to yeah, to include pediatric patients and adult patients for any of the medications being requested.
I guess I'm not sure how the pediatric patient meets all criteria.
Which criteria in particular, Dr. Smith?
Well, I guess if you move that adult patient line underneath group 1, that would sort of hit it, but it still doesn't sound like it's intended for pediatric patients. Like I'd almost rather have that that line stay separate and say adult patients in group 1 with a history of WHO functional class or a pediatric patient. Or maybe a different line that, or some kind of or, like adult or pediatric patient.
Yeah, so with this line, the WHO functional class would not apply to pediatric patients. So that's why we clarified adult patient has a history.
I know, but how this is written, it makes it sound like pediatric patients aren't eligible.
Oh, I see. Yeah, we definitely want to make it clear that these medications can also be requested for pediatric patients. So any other ideas as to how to make that clear would be appreciated.
About group 1 with the pulmonary arterial hypertension, doesn't that, I mean, it doesn't say adult or pediatric. I would think when I looked through this, I thought it kind of included everybody. It didn't, you know, so under diagnosis of pulmonary hypertension, that first box, group 1, I thought that the whole point for the adult part was just to say, oh, and only the adults are relooking these functional class histories. So I felt like, but of course I'm a pediatrician, so I bias. I read everything as assuming it already said pediatrics. So I'm glad people look to see that that detail is there. But I thought that would do that.
Well, thank you for that feedback.
Okay. Any other comment, question, or do we have a motion to edit the PA to make it clear that the group 1 pulmonary arterial hypertension, all of these be applied for pediatric, and make it clear that only the adult is a question about history of WHO functional class?
It could say any pediatric patient or adult with history of. I guess that's a motion to amend if we need a motion or just a suggestion.
Second.
based on the experts.
We have a second and a motion. I have a motion and a second. Do you have a in favor, all in favor to amend the PA?
Aye.
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 Any opposed? Any abstention? Okay, so the motion is to amend the PA to be clear on the W functional class for adult criteria. All right. With that, that is conclude the meeting for today. The next meeting will be May 11, 2023. The topic will be weight management. Do we have a motion to adjourn?
So moved.
All right, thank you. And all in favor? Any opposed?
Aye.
Aye.
All right. So
Thanks.
meeting adjourned. Thank you very much.
Nice day.